So thank you, Amir and Ted, for having me. Wonderful course as usual. And what better way to start a trauma course with a talk on spine? So the goal of this talk will be to identify what's unstable and what's stable in the cervical spine. And I just wanted to start out, I can't count the number of times that I've been consulted by my more non-spine colleagues for fractures that were missed in other situations. So, while I'm a bit tongue-in-cheek in terms of this lecture, it's actually really important to kind of cover the basics, and everyone is part of the same team and helps with identifying these injuries. So this is a table of cervical fractures, kind of a summary. We've got a usually stable, or sometimes unstable, and the always unstable. The always unstables are often very obvious, but they could also be non-displaced and hard to check out, and those are really the ones you want to not miss. The sometimes unstable, there's a bit more of a discussion about them, and obviously the usually stable are usually stable. So what is instability in the spine? I like quoting this White and Punjabi quote, which is the loss of the ability of the spine under physiologic loads to maintain its pattern of displacement, so there's no initial or additional neurological deficits, no major deformity, and no incapacitating pain. And so I'll cover kind of an initial evaluation, cervical clearance, radiographic assessment, as well as the different fracture types and a case example. So, according to the ATLS guidelines, all trauma patients should be presumed to have an unstable spine injury until all aspects of the spine have been adequately studied and the injury excluded. And so you start with your history mechanism. Anticoagulation is a big one because that could help alter the management, help delay management, and bring in other considerations. And you want to do a good, thorough exam to confirm any findings. Many times when patients come in, especially with polytrauma, they have distracting injuries that they're not even aware that they have weakness or deficits in certain areas. And of course, as we tell our residents, the rectal exam is of utmost importance and should be done on any trauma. So we'll start with this case example. This is a 45-year-old male who fell from a skateboard while reliving his young days. No other injuries. He denies any pain and weakness, has a GCS of 15, normal state of mind, and he was placed in a collar. On physical exam, he had no tenderness to palpation. He was neuro-intact with a normal rectal tone. And here you kind of see a summary of the physical exam that we look for all the different muscle groups, as well as we also try to see if there are any deficits, whether it falls into any of the categories of the spinal cord injuries, or if you have a spinal cord injury, whether it's an ASIA A, B, C, D, or E, depending on the level of function. But I won't dive into that too deeply right now. And so the previously discussed patient, he has no pain, he's neuro-intact, no distracting injuries, and so does he need imaging to clear his collar? And so based on the nexus criteria, with a patient who's got GCS of 15, no intoxication, no midline tenderness, and no deficits and no distracting pain, you don't need imaging. So you could theoretically clear the spine if the patient also has painless range of motion. Now, oftentimes in traumas, the patient's GCS isn't a full 15. They may have distracting injury. They may be intoxicated. And so in those cases, you either get a cervical X-ray or, in these days, a cervical CT. So let's go over kind of the imaging modalities a little bit to kind of see how to interpret them. And I'll really be focused more on the X-rays and the CTs in this section. And so here we have a straight lateral X-ray, which should include down to the top of T1 at the very least. And so you want to visualize the occipital cervical joint. If you can't visualize T1, you may ask for a swimmer's view, and you really want to assess the alignment, the disc spaces, and the soft tissues. And so you look down at the anterior longitudinal line, make sure it's continuous at the anterior aspect of the vertebral bodies. You look at the posterior longitudinal line, which is the posterior aspect of the vertebral bodies, the alignment of the spinous processes, as well as the interspinous distance, because any big gaps could represent an injury. You also look at the spinal laminar line, and so all these lines come together with these smooth arches. The other thing you want to look at are your facet joints. On the CT, it's seen a bit more clearly, and you really want to see them shingled on top of each other without any significant fractures. And you want to take great care to check the OC joint and the C1-C2 joint. You want to evaluate soft tissue shadows, and so kind of the rule of thumb is you want to have 6 millimeters of soft tissue shadows at C2 and 2 centimeters at C6. I can't count the number of injuries that I have further pursued and investigated and found just due to abnormal soft tissue swelling. As a little caveat, if the patient is intubated, this becomes a bit less reliable because the intubation itself could cause prevertebral swelling as well. So what do we do in surgery? We decompress what is compressed, and we stabilize what's unstable. And again, going into this cervical fracture summary, we'll discuss these kind of fractures and see which ones are stable, which ones aren't stable, and give a general outline on how to manage them. So we'll start with the upper cervical spine. The atlas supports the occipital condyle, is responsible for 50% of flexion and extension. The axis supports the atlas, which is the dens, and accounts for about 50% of the lateral rotation. Specific injuries to that level include occipital cervical dissociations, which cannot be missed. We've only really started getting literature on these patients in the past 30 years, just because, frankly, they wouldn't make it to the hospital alive. And these are very unstable, and if not identified early, it could then displace and lead to a catastrophic injury. So these are injuries that we take very seriously. Then you have the occipital condyle fractures, the C1 ring fractures, the dens fractures, and the Hangman's fractures. And so I'll start with this case of a 37-year-old male who was hit by a car. He was intubated in the field, seen to move all extremities, and his medical history is unknown. You have his imaging over here, and so you could see some widening at the C1-C2 joint as well as the OC joint, and angulation of the C1 relative to the C2, and I'll go into more details with that shortly to demonstrate it. And here you could see asymmetry on the coronal plane. You could kind of see that bow tie on the coronal plane over there, and you see that the interval between C1, C2 on both sides is not necessarily equal, and on MRI, you could see that even more on the coronal plane. And so this person had occipital cervical dissociation, and it got an occipital cervical fusion. So now we'll take a closer look at the anatomy. So going back to these images over here, you could see the red line over there shows widening of the C1, C2 joint. You look for any asymmetry of the occipital cervical joint or the C1, C2 joint. The C1 posterior arch often follows the occiput, which leads to widening of the C1, C2 interval, and you also have angulation of the C1, C2 joint. And you also have a V sign, the Atlanto-Downs interval, and all these are kind of soft signs that if you see them, it raises my suspicion that there may be something going on in the upper cervical spine. Avulsion fractures, either of a type 1 dens or occipital condyle fractures, which are usually stable and non-operative, could also signify an occipital cervical dissociation. So whenever we see these injury patterns, we just want to rule out occipital cervical dissociation. It's almost like a L5 transverse process fracture in the setting of a pelvic ring injury where the transverse process fracture isn't so meaningful, but it indicates a greater injury. And then, just like anything, these are dynamic fractures, and it might appear reduced on CT, and that's where it's important to kind of look for a lot of these soft markers. If you look at the swelling, the soft tissue swelling on the leftmost image, you could see that there's significant swelling in front of C2. And so that, in this case, would be the main thing that would hint to me that there's something going on. And so the initial management, time to diagnosis, is associated with mortality. They often have unusual cord injury pattern due to decussation of ascending nerves in the midbrain, which may occur in that level. They may have cranial nerve involvement. Generally speaking, I like to remove the collars and replace it with sand or IV bags and tape. The collars distract and extend the cranium, and that could make the injury a bit worse, but also I don't want people moving the patient, and people get very frightened when they see someone's head taped to the bed. And here you could see how there's widening across the OC joint. And so now I'll go to occipital condyle fractures. These are generally non-operative. You've got your type 1 where you have where the OC joint is involved. You have type 2s, which are lateral to the occipital condyle, and then you have your type 3s, which are the avulsion type injuries, which are generally non-operative, but you need to rule out an occipital cervical dissociation. Then you have your C1 ring fracture. Again, most of these are stable. What you are concerned is failure of the transverse ligament and having widening of the lateral masses, and so you get an upright open mouth odontoid view, and if there's lateral migration of the lateral masses, that's operative. If not, it's not. Dense fractures, type 1s are non-operative. Type 2s are kind of the femoral neck of the cervical spine. They're controversial, and there's a lot of literature discussing how to manage them. Type 3s, generally treated in the cervical collar. Hangman's fractures, typically treated with collar unless significant displacement on upright films. Then you've got the subaxial spine, which goes from C3 to C7. Its primary function is to support the head and maintain posture. And you have different mechanisms of injury, as seen in this diagram from the Allen Ferguson classification, which discusses flexion, extension, distraction, compression, and that leads to the combination of all of these injuries. Some of them are more stable than others. You have your facet dislocations, which could be locked, perched, or fully jumped. With these injuries, if you have a unilateral facet dislocation, you usually see up to 25% of a vertebral body step-off. Bilaterally, you have 50% vertebral body step-off or more. On the axial, you'll see what's called the reverse hamburger sign. You can see the regular hamburger shows the facets lined up, but if you've got a jump facet, it looks like the buns are flipped. And here you can see that you have more than 50%, or you have about 50% displacement, so you have bilateral jump facets. And so in the intact or incomplete cord injury patient, the next step is an awake reduction. The patient needs to be awake and examinable to know if the exam is worsening. And then if you close reduce the patient, fixation is no longer emergent, it just becomes urgent. If the patient's obtunded, you take him to MRI and then to the operating room. Continuing with unstable patterns, here you have a flexion teardrop, which is basically a flexion compression injury. These have a lot of neurological deficits associated with them. The vertebral body often is comminuted and needs to have a corpectomy, and often a 360-degree type of fusion, as you can see in this image over here. And so then I'll go to the somewhat unstable one. So you've got an isolated lateral mass fracture, otherwise known as a floating lateral mass fracture, and that's when you have a combined pedicle and lamina fracture. And so the lateral mass, or the lateral aspect of the vertebra, becomes free-floating and could spin, leading to a coronal malunion. And usually these are not catastrophic in terms of something acute, but could lead to a coronal malalignment as well as neck pain. If the alignment doesn't shift, these sometimes could be treated non-operatively, and that's a discussion to be had with the patient. The usually stable patterns are the ones that are obviously usually stable. You usually get upright images to assess for any subluxation or displacement, and if normal, it's typically okay to follow up with them in a couple of weeks with repeat imaging. That includes your extension teardrop, not to be confused with the flexion teardrop. This is more of an avulsion type injury of the anterior-inferior aspect of the vertebral body, and these are stable injuries. Then you have your isolated lamina fractures. These are non-operative, but again, it's key to take a look at the pedicle to make sure that it's not an actual floating lateral mass. Then your isolated spinous process fractures, if they're vertically oriented, it's non-operative. If they're horizontally oriented, it's actually a flexion distraction injury, which is an operative type injury. And so here we have a summary of all the cases, or for the most part, the cases that I discussed. Don't miss the always unstable ones. These could be catastrophic. And just a couple of special considerations. The ankylosed spine basically acts like a long bone. These will displace when these come in at night. I have the residents do neuro checks on them. These patients are often on blood thinners, and so it's very common to have an epidural hematoma, so neuro checks are very important. If they have neck or back pain, they have a fracture until proven otherwise. They often have multiple fractures at different levels. And these are patients where there was a whole case series of them going into MRIs intact and coming out paraplegic because they have kyphotic deformities. And to fit them in the MRI, people extend them, and that leads to a bad day. And just this one patient over here, this was a 40-year-old patient on a high-speed autoped, intubated at the scene with a traumatic brain injury. You could see that he has both widening at the OC joint as well as jump facets at the bottom. Again, look at the entire spine. Don't focus on the first injury that you take a look at. You could see that the lines are discontinuous here anteriorly as well as posteriorly. You could see that jump facet over there. You could see the widening of the OC joint. And you could see, even though the patient's intubated, he does have soft tissue swelling, but again, he's intubated, so you don't know if that soft tissue swelling is from the injury itself or from the intubation, but I always assume it's real and look closely. And you also have widening of the OC joint on the coronal view. But a couple hours later, he got a repeat CT and it closed down. Again, these are dynamic injuries, and this shows somewhat of how unstable these injuries are. And so he got an occiput to C2 fusion as well as C7 to T1 PSIF. And so, in summary, assume spinal injury until proven otherwise. Thorough evaluation is critical. Spine could be cleared with negative nexus criteria and painless range of motion. On imaging, evaluate the lines and landmarks and pay attention to all asymmetry on imaging. Thank you.